In this video, we're going to look at the specific input to the facial nerve nuclei within the brainstem. So what we can see at the moment are the two pre-central gyri within the frontal lobe. We can see the internal capsule and the genu specifically, which is the region of the internal capsule that allows these descending motor fibers, these upper motor neurons, to pass to the brainstem. In this case, specifically, the facial nerve nuclei. We can see a face here, and in order to appreciate the input of the facial nerve to these muscles of facial expression, we can just divide the face in half. So we can have a left and a right half, and we can also divide it into an upper and lower portion across the eyes. We can extend this midline up through to where an imaginary brainstem would be, and that's where we can draw in two facial nerve nuclei. So here we can see the motor nuclei of the facial nerve. We can remember that this nucleus is divided into two, so we have an upper portion and we have a lower portion. So this is for the upper face, and this region here is for the lower face. And if we remember, the upper portion are going to give rise to these lower motor neurons that are going to pass out and go and supply the muscles of facial expression either in the upper portion of the face or in the lower portion of the face. And obviously this happens on both sides. Now these neurons that I'm drawing here in purple are those lower motor neuron fibers. So these are your lower motor neuron fibers that are contained within the facial nerve. Now we know the facial nerve, we know it leaves from the cerebellopontine angle, it passes through the internal acoustic meatus to course through the facial canal before exiting at the stylomastoid foramen and then passing through the substance of the parotid gland to supply the muscles of facial expression. So this facial nucleus is embedded within the brainstem in the floor of the fourth ventricle, and coming out of it via the cerebellopontine angle, it passes towards the muscles of facial expression. So these are our lower motor neurons that are within the facial nerve, cranial nerve number 7. So it's important to remember that if these lower motor neurons were damaged, say there was a lesion in the parotid gland that damaged these lower motor neurons, or Bell's palsy had affected these lower motor neurons in the facial nerve, then you'd have complete paralysis on one side of the face. So complete paralysis down one side of the face because of this ipsilateral innervation. There's no crossing the midline once they've left the facial nucleus. So damage to the facial nerve leads to complete ipsilateral paralysis. But we're not so much concerned with that. We're concerned with the corticobulbar input. Now for the corticobulbar input, we can have two regions of the precentral gyrus. Remember, the precentral gyrus is divided into various regions that go to supply specific muscles of the body. Most laterally, we have the muscles of the face and the upper portion for the upper face, the lower portion for the lower face. So these corticobulbar fibers, or these upper motor neurons, leaving from the upper face are going to go to the upper portion of the facial nucleus, and they go to both the ipsilateral here and they also go to the contralateral. So they serve the nuclei bilaterally. An upper motor neuron is passing to the upper portion of the facial nucleus. So here we have our upper motor neuron. And this is going to happen for the opposite side as well. So here we have the upper face region, and here we have the lower face region. Here's the cell body of our upper motor neuron, and it is going to pass to both the ipsilateral upper face region and also the contralateral upper face region. So we have bilateral innervation, and this is like a safety mechanism. If one side is damaged, then the other side will be able to compensate that innervation. But for the lower face, it is slightly more complicated, because for the lower face you only have contralateral innervation. So you only have contralateral innervation. The lower face corticobulbar fibers do not innervate the lower face region of the facial nucleus on the ipsilateral side. It is only on the contralateral side. So we can draw that again on this side. Here we find we have our upper motor neuron coming from the lower face region, and that is just going to pass to the contralateral lower face region of the facial nucleus. So what we can see is that for the upper region we have bilateral innervation. So for the upper face we have bilateral innervation, but for the lower face we only have unilateral innervation, and that is on the contralateral side. So we have contralateral, unilateral innervation. So if we were to have an upper motor neuron lesion, sometimes known as a supranuclear lesion because it's occurring superior to the nucleus, a transient ischemic attack or a localized stroke within the genu, say, then we are going to knock out these upper motor neurons. So let's assume we've knocked out these upper neurons. Now, what is the consequence of that knockout going to be on the input to the facial nucleus? So we'll be able to see that this one here would go. We can see that this one here would go, and we can follow for the lower face that this one here would go. And this where that bilateral innervation is really, really important, because we can see that we have bilateral innervation to the upper face, so this nucleus is still receiving an input. So this nucleus will still, this upper region of the nucleus will still be able to activate these lower motor neurons, enabling the upper portion of the face, the musculature in the upper portion of the face, to contract. If we look at the lower portion of the facial nucleus and follow the upper motor neuron for the lower face passing to the lower portion of the facial nucleus, we can see this is lost here, but there isn't a second input. There isn't a second input, so this lower motor neuron then becomes defunct, and we cannot have contraction there. But because of the contralateral innervation, this lower region of the facial nerve nucleus on the ipsilateral side to the lesion still receives an input, and this means that this lower motor neuron enables the lower portion of the face on the ipsilateral side to the lesion is able to contract. So with an upper motor neuron lesion, you have an inability to contract the contralateral lower side of the face. An upper motor neuron lesion of the facial nucleus means that you have an inability to contract the lower portion on the contralateral side of the face. And hopefully with this diagram showing the connections, you can appreciate why that happens.